Welcome, and thank you for joining this Ask the Experts virtual event, Everyday Heart Health, Daily Habits that Make a Difference. I'm Dr. Maria Mountis, a Cleveland Clinic cardiologist. I'm joined by a panel of heart care specialists. We're here to answer your questions and share insights on how to build heart-healthy habits at any age, tips for lowering your risk of heart disease, and what to do after a heart diagnosis. Before we get to our questions, let's meet our panelists. They'll each briefly introduce themselves and share how they personally keep their hearts healthy. We'll start with Dr. Tyler Tagan.
Thank you very much. My name is Tyler Tagan. I'm a heart rhythm cardiologist, which is a cardiac electrophysiologist, and so I specialize in patients that have fast or slow heart rhythms, irregular heart rhythms, the most common of which is atrial fibrillation, and then also see patients with pacemakers and defibrillators. I've been practicing for 15 years now and have clinics here at the main campus downtown and also in Twinsburg and see all different types of patients that I just mentioned at both those locations. Something that I do for my heart is something I started when I was a fellow with my neighbor, which is that I run every morning. We meet at the curb at 5 a.m. and so it's cold on days like this. And most days we'll run 5 miles. We've got a group of about 4, and so that's good for my heart and also good for my mind to socialize and see those guys out there every day.
And now, Dr. Grant Reed, please tell the audience about yourself.
Thanks for having me. I'm Dr. Grant Reed. I'm an interventional cardiologist at the Cleveland Clinic. Interventional cardiologists, are procedural cardiologists. So we're not surgeons, but we do the most minimally invasive procedures on the heart, the coronary arteries and valvular heart disease. A big part of my practice is structural heart interventions, which we'll talk a little bit more about today. I practice mostly at main campus, but also at Fairview and Hillcrest hospitals doing structural heart procedures. One thing that I like to do to keep my heart healthy is spend time with my family. Right? I have 3 young children who keep me both physically active, but also very emotionally centered. I think that's very important to have people around you that are in your corner and can help you live a heart-healthy life. So.
Finally, Dr. Ashish Suraju. Ashish, please tell the audience about yourself.
Thank you very much for having me. I am a preventive cardiologist, and that's my area of specialty. So in essence, I see folks who either have an interest in reducing their risk for heart disease, mainly coronary artery disease. They have risk factors for coronary artery disease and are interested in improving them and getting them to an optimal level, or they have a family history of cardiovascular disease and they want advice on how best to optimize their levels. I practice at the main campus here at the Cleveland Clinic. I've been practicing for about 5 years now. And recently, one thing I did for my heart health was to buy a walking pad because it's been so cold out in Cleveland. It allows me to get to 7,000 steps a day without having to brave the cold every day.
Thank you, Ashish. Again, I'm Dr. Mountis. I've been practicing here at main campus for about 18 years. My area of expertise is heart failure and anything related to that. So that could be seeing patients who have been diagnosed with a cardiomyopathy or weakened heart muscle, given a diagnosis of heart failure, whether it's with a normal squeeze of the heart or an abnormal squeeze of the heart. And really, any patients that have any type of exposure to toxins that can affect the heart. So it may be seeing patients once a year, or it could be really being very involved with patients that they may be very sick and need heart pumps or heart transplants. So really a wide spectrum of individuals that I see. I do see patients primarily at main campus, but I also go to Independence a couple times a month and see patients there, and now most recently Beechwood for some weekend hours. The one thing that I do daily to protect my heart is I don't brave the cold and exercise, as some of our panelists here. What I do is make sure I get enough sleep. I try and get to bed by 10 or 10:30 and wake up around 5. Make sure that I get around 7 hours of sleep, as we know that sleep health is really important to heart health. And this time of cold winters in Cleveland, I make sure that my vitamin D level is appropriate and that I'm up to speed with my immunizations. So now it's time to answer your questions. We have received hundreds of questions, so we will attempt to answer as many as we can. I want to open up our first question to Dr. Suraju. How prevalent are hereditary factors in heart disease? If members of my family have heart disease, should I see a cardiologist even if I don't have symptoms yet?
When we think about heart disease, specifically coronary disease, and that's blockages, in the arteries that supply the heart muscle, some data suggest that maybe 40 to 50% of coronary disease is heritable, meaning there's some genetic component driving coronary disease there. But this is often not a single gene or a single mutation. This could be many, many hundreds of genes that could be driving this, and sometimes it's hard to get to the bottom of exactly what that genetic issue is. But if you have a family history of someone who's had a heart attack under the age of 55 if you're a man, under the age of 65 if it was a woman, if you have a family history of high cholesterol at a young age requiring medications, a family history of sudden cardiac death at a young age, these are all conditions that I think would really benefit from seeing a cardiologist early, because cardiologists can add to the workup, take a careful history, do appropriate testing, and then start proper measures to reduce your risk as appropriate. I'll throw in one fact here. There's a condition, for example, called familial hypercholesterolemia, or FH, condition of high cholesterol from a young age. We think that's only diagnosed in 10 to 30% of people. This is highly treatable. You treat that, your heart disease risk is nearly the same as that of someone who's never had it to begin with. So it's incumbent for us to hope that individuals who have the family history come and see us so we can get them treated.
One thing that I wanted to just ask following that question is lipoprotein A. Is that something you could briefly mention with the familial hyperlipidemia?
Absolutely. So lipoprotein little a, or LPA, is something that's been in the news a lot. There's a lot of research going on. But in a nutshell, it's a particle similar to LDL, which we know a lot about. It is causative of heart disease, of plaques in the arteries, and also of aortic stenosis, which is narrowing of the aortic valve. We don't have approved therapies, specifically approved to lower this, but this can explain a family history of heart disease at an early age. And if you have that, even if you don't have symptoms, there are opportunities to improve your risk by controlling the other risk factors more aggressively than you otherwise would have if you hadn't tested for this. So we encourage testing for lipoprotein(a), especially in people with a family history of early heart disease, because it is still actionable even if we're waiting for the trials to result.
The next question is for Dr. Tagan. Is it normal for a resting heart rate to increase as one ages?
We get this quite a bit in our clinics, and there's a lot of different factors that go into resting heart rates. It is very common for people to have lower resting heart rates when they're cardiovascularly fit and when they exercise. In general, as we get older, our resting heart rate actually goes up a little bit, and so that part with it dropping from a physiologic standpoint probably doesn't make as much sense. One of the things, though, that I look at in my clinic that's important is if someone's having a lower heart rate and they're feeling tired, then that may be related to a sinus node dysfunction. So we call the sinus node the pacemaker, the natural pacemaker in our heart. And if that starts to slow down and someone has a lower heart rate without reversible causes, we would check thyroid, we would check metabolic changes, check endocrine disorder. And if there isn't anything with those that we can change, then perhaps that patient would need a pacemaker. If it starts to go up, then we need to try and figure out why it is that someone has a higher heart rate, which could be some other physiologic parameter with that. In general, though, I think it's safe to say that heart rates don't change a whole lot unless there's a physiologic change with conditioning.
How do you counsel patients who focus a lot on their smartwatches, that the rates are, it's always 50, or I see it really go up to 110? Do you put a lot of weight into that?
Yeah, this is the new world that I live in because everyone's got a smartwatch, and it gives us so much information that, in a sense, there's overload with this. It's just coming at us in ways that we didn't understand before. And so there are probably answers that are going to come out of this that are different, and that will be exciting for us to understand. I would say that all of this is a screening tool. And so if your watch is telling you that you might have AFib, or that you might have a slower heart rate, or that the rate is different than what it was before, then it could be worth reaching out with that information to a doctor. but none of it, frankly, is strictly speaking diagnostic. And so if that were to come up, then we would consider monitoring and so forth, and I'd see them in clinic. By itself, the smartwatch just gives us a hint at what might be going on, but it's not diagnostic.
Thank you. The next question is for Dr. Reed. Can you please explain the calcium score as a screening tool, and what can I do to lower my calcium score?
Coronary calcium score CT scanning is a very commonly obtained test for the screening of coronary artery disease. And building on the prior question about what we can do to prevent coronary artery disease and heart issues, it's important to screen for that as well. And coronary calcium, what this is a specific finding on a CT scan. Usually the CT scan is obtained for the specific reason of looking for coronary calcium, but you can sometimes, and I get referred patients who have coronary calcium found incidentally on CTs done for other reasons. And what this essentially means is that there is some calcium which is correlative with atherosclerotic plaque or cholesterol buildup in the artery. Where there's calcium, there always is some plaque. So if there is coronary artery calcium, that does diagnose coronary artery disease. Now, your burden of calcium can correlate with your extent of coronary artery disease and how narrow the arteries are. So oftentimes, this is the first test that we get when we're looking for coronary artery disease, and then that leads to other additional testing, such as a stress test, an echocardiogram, or perhaps a cardiac catheterization, depending on how symptomatic patients are. Once the calcium's there, it never goes away. That's a question I get asked a lot is, what can I do to lower the coronary calcium score, or do I need to have this done over time and continue to follow this? And in general, the answer is that once the calcium's there, it's never going away. Doesn't necessarily mean that there is a blockage, but that usually means that additional evaluation is needed and that you need to work on lowering your risk factors such as your cholesterol, work on your diet, avoidance of smoking, and having a heart-healthy lifestyle.
What happens after you've been diagnosed with a heart condition? The first thing I tell people after a diagnosis is to truly not go online and start searching, doing searches, because you don't know what websites that you're getting onto and what information, if it's accurate or inaccurate. One is to really find a practitioner, a cardiologist locally, or a second opinion to find out and understand what the condition is. If you've been diagnosed with a cardiomyopathy or a weakened heart muscle, to understand, well, one, what caused it, and what can I do to move forward and help really have a good life expectancy. Do I need medications? Do I need preventative cardiology? Do I need an electrophysiologist? So there's multiple things to do when you've been diagnosed, but the first thing is to not panic. Now, there are some times where we say, listen, if there is a group of symptoms that you're having, then you need to be seen sooner than later. So you're having chest discomfort or shortness of breath that's just not getting better with rest. If your blood pressure is very high or very low, or your blood work is very abnormal, those are really things that I would prompt someone to say, pick up the phone or have your family member, a friend, really guide you through, calming, and make sure that you have an appointment with a trusted provider, and to really develop a good rapport with that individual, and to take the medications and whatever therapies are instructed. Dr. Suraju, I'm interested in your advice on diet. I see conflicting opinions from experts. What's the best approach?
This is such a common question, and it's not an easy question to answer. But overall, I would say if you're thinking about just health in general without a specific goal in mind, then the Mediterranean style diet has probably the biggest body of evidence behind it for longevity, for reduced heart disease risk, and for other benefits as well. The DASH diet is also very good. That stands for Dietary Approaches to Stop Hypertension. And for folks who are particularly interested in controlling their blood pressure, the DASH diet is excellent. There's a lot of overlap between the Mediterranean diet and the DASH diet, and the components of those diets are not going to seem like rocket science to anybody that hears them. Lots of vegetables, lean meats are allowed, avoiding processed foods, focusing on olive oil, reducing salt intake, minimizing alcohol intake. But then there are sometimes specific dietary approaches depending on your health goals. For example, if I see a patient from an electrophysiology colleague who has atrial fibrillation and would like to lose weight, we may implement a specific dietary approach that focuses on that. So speaking with someone who has expertise, like a registered dietitian or a physician who's comfortable with nutrition, about your specific goals can be very useful. But if you're shooting for general health, I think the Mediterranean diet is a great place to start.
You know, if I can interject on that, because this comes up all the time with atrial fibrillation in particular in my world. And a lot of the folks that we see with atrial fibrillation have diets that need to be adjusted. A couple of things that I think are most important with that. Number one, alcohol really needs to be 0 or very little once you've been diagnosed with atrial fibrillation. The evidence is growing that it probably needs to be 0. And then if there is obesity, then that needs to be a primary target. Even if you're coming in with atrial fibrillation and that's what you're thinking about, then many times the take-home with that visit is the focus on diet and perhaps treatment of sleep apnea and avoidance of big triggers like alcohol. And so that couldn't be more important in our practice as well.
What do you think of the kind of earlier implementation of GLP-1s to really help this cohort of individuals with obesity, sleep apnea, atrial fibrillation preventative?
Absolutely. So I think, you know, this is such a hot topic. But let's put aside cost and access completely and pretend that they're not issues. Then I think, yeah, there are a lot of patients who would benefit from GLP-1s to supplement their lifestyle approaches, because in some people, modifying the diet works great because there is a lot to modify. But in others, in whom there may not be a lot to modify and who may have underlying sort of pathophysiology that is still contributing to obesity, then these medications like GLP-1 receptor agonists, with good counseling, right, as an adjunct to lifestyle measures, they never replace lifestyle measures, they're always an adjunct. They can be a great choice. And we have so many different studies now showing benefits across the spectrum, not only weight loss, cardiovascular risk reduction, liver disease, obstructive sleep apnea, right? So I think there's a very strong place for them in the treatment pathway.
Dr. Tagan, why does atrial fibrillation come back after an ablation?
The reality of atrial fibrillation is when we see folks, we focus on 3 primary foundations of treatment. One is to make sure we understand what the structure and function of their heart is, because that can impact it, and that would potentially impact the outcome of any rhythm control treatment strategy, including ablation. The other is stroke prevention, and so we need to really understand what that is with risk factors. And then the third are symptoms. Looking at all of those, we try and come up with some sense of what the likelihood of success is for an atrial fibrillation ablation and whether or not someone would need to have another ablation. Historically, we haven't done as good a job tying that success and what that really means to a patient's experience. If the idea is a patient going to benefit from an ablation, then the likelihood of that is about 95% based on our evaluation. If the idea is, would a patient have a minute or two of atrial fibrillation over a year, then that falls to 70-75%. So this question really gets at how careful we are at looking at this. But in my opinion, it has most to do with what matters to a patient, which is stroke. It's making sure their heart is healthy, and it's making sure that we're taking care of these occurrences that can be really scary. Once we understand all that, it falls into 2 categories. One is that when we focus on an atrial fibrillation ablation, the idea is to isolate the triggers, the short circuits inside of pulmonary veins. They bring the blood back from the lungs after the blood's picked up oxygen into the heart. And those triggers connect to the back wall in that chamber and cause AFib. So we're trying to electrically isolate that. One reason why we might have a recurrence is that there's not a durable isolation and there's a growth that connects that trigger back to the heart muscle. The second is that the heart muscle is changing all the time and the electric connections change. And there may be some other trigger that's not those pulmonary veins later on that's causing this. And so it ends up as a complicated reason. The final point that I'll make, though, is that the energy that we use now to do these ablations is different than what we've used in the past. For decades, it's been with thermal energy, which is either heat or cold, cryo or radiofrequency ablation. Now it's with an electric signal that we can program just for heart tissue. That's something that we've led the clinical trials on here, and I think will give us a better result with fewer recurrences and fewer need to go back in and do second and third ablations.
It's fascinating. Thank you. The next question is for Dr. Reed. Can coronary artery disease be reversed or just stabilized?
There are a lot of exciting new advances happening in coronary artery disease, both from the preventative aspect but also the treatment aspect. So coronary artery disease is most commonly caused by atherosclerotic plaque or cholesterol plaque building up in the arteries. And the primary cause of that is dietary, but genetics are a big part of that too. So your family history plays a big role. So once you have established coronary artery disease, it is unlikely that there'll be significant regression. However, there are some data, and a lot of data which was led here at the Cleveland Clinic, that with very aggressive measures of lowering the LDL cholesterol as low as possible, that there can be some regression of coronary artery plaque burden. Now, clinically, what that means is that you should do all you can to limit the progression so that this doesn't get worse. And once you have a heart attack, once you have a stent which is placed, even if it's not a reversible process, you can do all you can to halt it and stop it from getting worse. And with very aggressive dietary measures, such as the Mediterranean diet and statin therapy or other lipid-lowering therapies to get the LDL cholesterol less than 55 milligrams per deciliter or as low as possible, and treating other cardiovascular risk factors, then you're going to maximize your opportunity and chances for stabilizing it and hopefully having some element of plaque regression. Now, that hasn't necessarily played out into clinical outcomes yet, but when we do IVUS or intravascular ultrasound-based assessments of coronary arteries in patients with very low, very low LDLs, we have noticed some plaque regression. So this is an exciting area that hopefully will speed up more research being done, because that really is, in many ways, what we're chasing is plaque regression and being able to prevent heart attacks before they happen.
Can you ever recover from heart failure, or once you have it, is it just managed? So I'll go ahead and take this question. So it's a complicated topic. So, one thing is we have to be careful with the words that we use. So once someone is diagnosed with chronic heart failure, whether that's chronic systolic or diastolic heart failure, it is, in my perspective, a chronic condition where you can have many years of stability, but you certainly can have then lows depending on if something kind of worsens it. So for example, let's say you have coronary disease, and that coronary disease leads to heart failure. Once that coronary disease is stable and we start someone on good medical therapy, typically we use a combination of 4 medications called guideline-directed medical therapy to help stabilize heart function. Someone can live a very normal life expectancy, even with an ejection fraction that isn't normal. So I never use really the words cure when it comes to heart failure. There are cases where there are certain types of insults that once you take away that insult, you can have regression or you can have normalization of heart failure. But once there's been some kind of insult to that heart, that there's typically an increased risk that it could happen again. We have about 100 genes that have been linked to a diagnosis of heart failure or a weakened heart muscle, cardiomyopathy, that predisposes you to progression of that heart failure. So once you take away insults, whether that be alcohol, whether that is chemotherapy agents, obesity, sleep apnea, you can have normalization, regression of how thick a heart muscle is. So you really can have an improvement, but I would never say that it's fully cured. It would be something that you would live with and want to see a cardiologist at least once a year. So Dr. Suraju, please explain exercise guidelines for older adults based on factors like resting heart rate and current fitness level.
So the first thing I'll say is to think about quantity of exercise. So in general, you want to aim for 150 minutes of moderate intensity exercise per week. Now, how do we define moderate intensity? One sort of rule of thumb is if you can talk to someone but you can't sing a song while you're doing that exercise, it's probably moderate intensity for you. Now, what that is probably going to be different for everybody based on their current level of conditioning. Right? So that's a good place to start. Now, with all the wearables that we have, we already spoke about a little bit, folks are tracking their heart rates with exercise and at rest. And is there a good goal to aim for? It probably varies with everybody, but in general, if you're looking for a target, it's reasonable to aim for around 50 to 60% of what we call your maximum predicted heart rate, which is quite simply 220, the number 220, from which you would subtract your age, and you halve that, and that's a reasonable place to start for exercise, especially if you're just starting out. But I caution people against trying to aim for a specific number on the watch as your target. You really want to exercise, to that sort of moderate intensity level for 150 minutes a week, do resistance exercises 2 or 3 times a week. And if you don't have time or feel too tired to do all of that, just move every day. Try to get 7,000 steps a day. If you can't do that, try not to be sedentary every day. So aiming for, I think, achievable goals to start off makes a lot of sense. But certainly if you have a watch, you can start off with those heart rate goals and then work your way up depending on how your body responds.
One thing that I found very helpful in your section of preventative cardiology is the ability to refer a patient for an exercise prescription.
Yes.
Is that something you can
Absolutely.
elaborate on?
And the exercise prescription program, not something that's very common at institutions around the country, but it's a fantastic resource for pretty much anybody. There's no gatekeeping there, but you would come in, you would exercise on a treadmill with an EKG monitor, and then you sit down with an exercise physiologist who's an expert, who supervises cardiac rehab patients, so they have a deep understanding of exercise physiology, and they create a personalized plan. What heart rate goals to aim for, how much to hydrate, even what sort of exercises to do, what sort of equipment to buy. So that's a fantastic resource for people who are interested in very specific guidelines. And like I said, there's no gatekeeping. Anyone's a candidate for it at our institution.
Thank you. And to talk about exercise again a bit more, Dr. Tagan, what exercise tips do you have for people with atrial fibrillation?
I think piggybacking on that point is that it matters a lot for atrial fibrillation, and it matters to start with something that's structured. So there was a trial in Australia where they took about 200 patients. Half went into a group where there was a structured program. They were assigned to 150 minutes of exercise a week, and the other half was just told to continue with what they were doing, and it could be exercising or perhaps not. These were not folks that were getting on the track and running hard intervals or marathons or anything. Sometimes it was brisk walking, sometimes it was swimming, but it was structured. And so they had someone that was going to help them along. And over 6 months, they increased the volume from about 150 minutes to somewhere around 200 minutes. The group, and all the patients had atrial fibrillation. And the group in the structured program with exercise had half the amount of recurrence as those that weren't in the structured program. We've always known that this should help, but I think that with that trial, it's absolutely become a part of what I recommend patients do. And not just me saying, hey, you should go out and try and get something done. I think having a formal program, whether it's with our program here or something at Silver Sneakers, something at the YMCA, I don't know that it matters that much if you're walking or running or even lifting weights. I think all of those things can help, but it's something that you're doing somewhere between 2.5 to 4 hours a week and really committed to it. And then the key on so much of this, I think, with exercise is that you can't jump right in and think that you're going to be where you were whenever it was the fittest time of your life. You've got to just stay committed and consistent. And some days aren't going to be that great, and it's just going to feel like you hardly did anything. But you did. You showed up and you got it done. And that's, I think, the most important part of exercise And it certainly applies to the folks that I see with heart rhythm conditions.
Great advice. Dr. Reed, what should I do to protect my heart after a heart attack?
And I think just expanding on the discussion that we've had, when you have a heart attack or you have a major cardiac issue, and I think it's important as patients and as physicians that we use this for motivation, right? Because you have to start somewhere. A lot of patients will recommend regular exercise. You can almost see that they kind of tighten up, like they know that recommendation's coming and they know how hard it is for them. And not everyone can exercise because of orthopedic issues or because of certain chronic health issues that limit them. But I think that, when you have a heart-related issue, or just in general in all of our lives, you have to start somewhere. You have to take that first step. And no matter how big or small it is at first, little changes and little things add up. And just like if you were to take someone over the course of a year and you have a 30 or 40 pound weight gain, it's not like they gained that all at once. And it's like watching your kids grow, which is something very relevant to me now. Is you look back on pictures and you're like, wow, when did they get this old? And you remember when they were still kids, and they'll always be that way to you to some degree. Right, it's the same way for yourself. And just like big changes can happen negatively very gradually, they can happen favorably as well. So take that first step. Don't let your health and your medical issues dominate your ability to make positive changes. So when I take care of patients that have heart attacks, I think I'm in that unique position that, just very fortunate to be able to help patients oftentimes with a life-saving intervention. But helping them realize that was a big event can sometimes be challenging. We've gotten so good at treating heart attacks that patients come in, and then we put a coronary stent in. It takes less than an hour, and they feel oftentimes symptom-free within the first several hours afterwards, and they don't quite realize what happened. So it's our job to say this in a compassionate way that this was something which is life-threatening. It's an opportunity to use this as motivation to change your lifestyle. And this is why it's such a great field, is that we can do these things that tangibly benefit someone's life and then develop these lifelong relationships that then become a focus on secondary prevention. So I'm very fortunate to be able to work with patients and meet them before the heart attack happens and talk about prevention with some of the things that we've talked about, but then also to have these lifelong relationships afterwards. So, once you have a heart attack, there are so many things that you can do and that you should do. Number one that we should do as physicians is motivate patients to make strong, guideline-directed changes in their life so that they can live a life hopefully without another heart attack event. There are several medications that we typically do start for patients, but ultimately we as a team, between physicians but also with patients, need to motivate our patients to live a heart-healthy lifestyle, and that's often the most challenging thing.
The next question is for Dr. Suraju. Are there any supplements the panel recommends for long-term heart health?
Our institution, and one of my colleagues actually led a study about this just a few years ago, where we looked at supplements and how well they reduce LDL cholesterol, which we know causes heart disease, and it's a modifiable target for heart disease. So the more you lower it, the lower your risk of heart disease. And this study looked at some of the most common supplements that folks might be taking, right? Coenzyme Q10, red yeast rice, etc. And unfortunately, none of them were able to achieve proper LDL lowering, especially when compared with the lowest dose of a statin medication. And so, that study, I think, sort of crystallizes into research what a lot of folks have suspected, which is that taking supplements can be a bit of a gamble as to whether it's going to work in the way we think it works. The side effects of taking supplements, interactions with medications, I think these are things that we can't dismiss, and we can't look at supplements as a safer or more natural alternative to prescription medications. So in general, I don't think we are in a position, at least I'm in a position, to proactively recommend a supplement for heart health beyond the things we've already talked about, right? Excellent lifestyle, a good diet, which should really supplement you with a lot of the things that are sold as tablets separately, good exercise, excellent risk factor control, I don't think supplements will be able to adequately replace the benefits of doing all of that in a comprehensive manner.
Thank you. Next question, is the fatigue I'm experiencing normal with chronic heart failure? That's a little bit of a complicated question because fatigue can be multifactorial. So when a patient comes in and they explain to me that they're having fatigue, I have to be a bit of a detective to really understand what they mean by fatigue. Is this new for them? Is this something that's worsening? So patients with chronic heart failure absolutely can have fatigue. And if I am concerned that their trajectory is actually worsening, and I do believe that that fatigue is because of their heart dysfunction, then we go down a certain pathway of trying to understand what their cardiac output is, how much blood flow is leaving the heart, and we can assess, how much they could do with a right heart catheterization as well as a metabolic stress test. But most of the other fatigue is actually really reversible at times too. We'll question whether this is a low blood pressure or low heart rate issue because of the medications that they're on. And by decreasing those medications, we can actually improve some of their fatigue. We'll also be a little bit of a detective and sort out when they go to bed, what their sleep habits are. Many people really stay up at night, just doom scrolling on their phones and not really getting appropriate sleep. We want to ensure that if they do have sleep apnea, that they're using their sleep machines. If they've not been tested for sleep apnea, we'll certainly refer them and get them tested. But also we want to make sure that their labs are not abnormal that could be leading to fatigue, whether that's an abnormal thyroid lab, whether that's abnormal blood counts, abnormal vitamin D level, or kidney dysfunction. And sometimes there is an underpinning of depression or anxiety in many of our patients that experience cardiac disease, including chronic heart failure. So it really does a little bit of digging on our end to sort out fatigue. But in general, if someone is well managed with a diagnosis of chronic heart failure, they should be having more good days than bad days. And once that changes, that's when we have to reassess. Dr. Tagan, what are the expectations and challenges of living with an implanted pacemaker defibrillator?
These are two different things to start with. A pacemaker is a device that we use to control heart rates when they're too low, sometimes to treat heart failure. And a defibrillator always has the ability to pace, but by itself, its function is to prevent sudden cardiac death. If a patient has an arrhythmia that comes from the bottom chamber, from the ventricle, then it would see that and deliver a shock. This is a complicated relationship that we enter into with patients. And there are really three key players in this kind of relationship. One is our device clinic. That's where we check all of the pacemakers and defibrillators. That's where all of the information is housed. The way things work now is if a patient has a pacemaker or defibrillator or a loop recorder or any electronic device, then that information is sent back to our office remotely, and then we get updates on how well the device is working, whether it's providing the right therapy, whether there's an arrhythmia that we need to treat. All of that information is then sent to me, and I'm the second part of the team on this. And then I need to make decisions with the patient about where the therapy could change based on that. The third, which is the most important part of the team, is the patient. And the reason for that is this is not the kind of therapy where we just put a pacemaker or defibrillator in and then things are going to get better. These devices have become very complex, and part of that complexity is that it's going to require some tweaking along the way in order to get the optimal benefit. The devices can now see how we breathe, see how we move, make changes with pH, deliver an electric impulse milliseconds apart that would make an enormous difference in someone's overall heart function, how they feel, whether they're really tired when they get up to get something to eat, or whether the device is accommodating for that increased demand and their heart rate increases. And so all three of those things need to be aligned, and in order to get the most out of a pacemaker and defibrillator, a patient really needs to enter into that therapy with that in mind.
When are you too old for a heart procedure? What do the doctors consider?
As an interventional cardiologist who treats patients with coronary artery stents and also valvular heart disease interventions like transcatheter aortic valve replacement, TAVR, and other procedures, this is actually a very common question. Oftentimes I get referred patients who are in their 70s, 80s, and 90s. And I would say that really age is really a number. You can have a biologic age and a chronologic age. And I sometimes will see patients who are in their 70s who have a lot of medical issues and are actually sicker than my 80 or even early 90-year-old patient who may have led a healthy lifestyle and been fortunate to not have health-related issues. So I would say that it's less about the age number and more about how functional the patient is, what are the medical problems they have, and what their quality of life is. If they have a good quality of life and they're functional and they have a good life expectancy of at least a couple of years, then all interventions should be considered. However, it's important to, I think, not only as physicians be able to say what we can do, but what we should do, and that is aligning with the patient's expectations, with their quality of life and what their goals are. And I think that's one of the things that I enjoy the most is counseling patients through some of these tough decisions, because just because we can't do something doesn't mean that we have to. And a lot of times patients have somewhat unrealistic expectations that we can fix absolutely everything. But one of the great things about being here at the Cleveland Clinic is that we have, in many cases, helped to develop many of the technologies that can extend patients' lives, and we can apply these technologies to patients even when they're elderly, as long as they have a good quality of life, and we can extend that with our therapies. So Tyler, what do you think from an EP perspective?
I think the electrophysiology interventionalists, it has very much the same approach, which is that there is really no age that we would say that that's it. There's no cutoff for any of these procedures. And the answer for any patient is that if you think you might benefit from one, then you're always welcome to a second opinion. I think that's a good idea, especially here, because we see so many folks that have unusual conditions, and sometimes that's age. Within EP, there is a little bit of a difference with procedures. There are therapeutic procedures that we're doing that should help people feel better and potentially live longer. That would be ablations of atrial fibrillation, for example, sometimes ventricular tachycardias, SVTs, pacemakers when someone's heart rate is too low. And then there are procedures that we do that are really prevention. They don't make you feel better. If someone has a low ejection fraction, which is the amount of blood that gets pumped out every time the heart squeezes, they have heart failure, and I think that they're at increased risk for sudden cardiac death and might benefit from a defibrillator device, then that's preventative. They're not going to feel better just because I place an ICD. And so there is a point where that doesn't make as much sense at a patient who's older. The same could be said for a Watchman device. That's a procedure that's relatively new over the last couple of years, where a patient that has atrial fibrillation, who's at increased risk for a stroke, but can't stay on a blood thinner, either from bleeding or from other reasons why other doctors think that that's not a good idea long term, could benefit from the placement of that kind of device where we block off the area where the clots can form. That's preventative. They're not going to feel better other than they're not on the blood thinner. And so part of the discussion with this is to really hone in on differences with patients and make sure that we're making good decisions on things that can make you feel better as you get older versus things that are really preventative and are less important, frankly, as you get older, when we need to focus mostly on quality of life and not prevention of things that could happen potentially over 5, 10, 20 years of time.
Dr. Suraju, what are the latest findings on statins, both the proven benefits and the emerging safety or efficacy concerns, and how should that shape our treatment choices today?
Statin therapies are, this category of medications that they've been around for so long that we've managed to say a lot about them, both in terms of how much they benefit people, including something that Grant was talking about earlier, where folks who received high-intensity statin therapies saw some regression of their plaque. So there are established, proven benefits in reducing cardiovascular risks, in stabilizing plaque, and in regressing plaque. And that's been shown over tens and hundreds of thousands of patients over decades and multiple studies. Now, in terms of the side effects, there are a couple that I think are things that we should tell patients about. there is a risk of muscle symptoms. It's probably much lower than what we think it is. And studies where the patients did not know what they were taking. In one study, for example, 90% of symptoms that happened with the statin also happened with a placebo pill when folks didn't know what they were taking. So there's an element to that that's more complex than we think, right? But muscle symptoms can happen, and the vast majority of those are reversible. There has been concern about memory issues, but really this tends to be most of the time a very rare, maybe a brain fog type sensation, but that tends to go away very quickly, even if that happens. At very high doses of high-intensity statin therapies, there can be an increase in blood sugar levels, and that's been shown. But for the vast majority of people who have a reason to take a statin, like they have diabetes, they have established heart disease, they have high risk, they have a family history of high risk, generally these risks are outweighed by the benefits of reducing the risk. But like with every medication, it's important to discuss the risks and benefits with your physician. What makes the discussion much more interesting now, as I'm sure we all do in our clinic, is that we have a number of other therapies that can lower LDL cholesterol. Right? We have not only pills, but injectables that are extremely potent. Of course, there's no free lunch. Everything has its own set of rare side effects, but that creates for a much more complex discussion with folks who have had issues with statins, because now we have all these other options available, ezetimibe, PCSK9 inhibitors, inclisiran, bempedoic acid, etc., to reduce the LDL cholesterol. So there are many other options if you're trying statins and find that for some reason they're not agreeing with you. And there's a lot of exciting research in this area as well. So I have no doubt that not only with LDL cholesterol, but also with Lp(a), we're going to be seeing some exciting findings over the next few years, many of which are from the Cleveland Clinic.
Dr. Reed, what are some of the new techniques or procedures for treating valve disease?
At the Cleveland Clinic, we have been really fortunate to lead the way in developing innovative treatments for patients with valvular heart disease, from the early days of valvular heart surgery to now percutaneous therapies based with catheters. So we can now replace the aortic valve without even making an incision in the body. This is called transcatheter aortic valve replacement, or TAVR. This is where a large part of my practice focuses right now. And we were involved from the very early days, the earliest days, one of the first U.S. centers to do this, to now spearheading this to being a mainstream therapy which is approved in patients at all levels of surgical risk. And that is going to, and it has changed the therapy of patients with aortic valve stenosis dramatically. So now we can offer TAVR as a minimally invasive treatment option for patients. It's just been one of the greatest medical advances that I've seen in my lifetime. Building on that, we have a wide range of therapies for the mitral valve now. We do mitral valve clip or transcatheter edge-to-edge repair therapy. That is mitral valve clip or another related device. And this allows us to put a small device on the mitral valve to decrease its leaking or to improve mitral valve regurgitation. We have upcoming therapies and actually just received our first FDA approval for a transcatheter mitral valve replacement system. And this is on the horizon to now fully replace the mitral valve without surgery. And will be useful in a subset of patients that have severe mitral valve regurgitation and mitral valve stenosis. And similarly, now we have therapies to treat the tricuspid valve, where we can do tricuspid valve clipping or repair and replacement therapies. On the horizon, we have a range of different valve therapies undergoing clinical trials, such as bicaval valves, or valves which we put in the superior and inferior vena cava to replace the function of the tricuspid valve, to other therapies for interventional heart failure, such as interatrial shunt therapy to reduce symptoms in patients with heart failure. Many of those therapies are investigational. And at the Cleveland Clinic, we are referred patients from all over the world who want another opinion and maybe don't have access to these therapies at their local institutions. So we're just very fortunate to be able to offer this, and so much of this is a team discussion between all of us here. For example, I work with all of you on a daily basis about difficult patients, which I'm just honored to be able to lean on all of you for your opinions for, but now to be able to treat patients in this way in conjunction with our surgical colleagues, it's just one of the most rewarding and exciting things. So this is truly where innovation meets patient care. It's one of the things I think that attracts so many of us to the Cleveland Clinic, so we can focus on things like prevention to help prevent these diseases from happening in the first place, but then once we have to deal with them, we have innovative therapies which can be tailored to each individual patient.
We have time for one final question. At what point should someone consider getting a second opinion or follow-up at Cleveland Clinic? For example, is it beneficial for someone to have a primary cardiologist in their hometown and then go to Cleveland Clinic as well? I'll let you kind of,
Sure.
Because you really gave us a good overview of who these patients are that come to you for these innovative valve procedures.
This is actually a large part of my practice, is patients who I co-manage with other cardiologists. And these may be patients who come here for a second opinion initially, who then get a therapy, and then just have loved the care that they've received here, so then they become lifelong patients for us. The question of when do you seek a second opinion, I think, is an individual one. However, I would say that in all cases, we're more than willing and happy to offer an opinion about your heart health. And many patients, they just want to be established with the Cleveland Clinic cardiologist in case something happens. And I get a lot of second opinions for patients who are for prevention, or maybe have had a heart attack and they just want an opinion about secondary prevention, and they're feeling well. But they just want that peace of mind that they have a world expert in their corner. And I'm honored to be considered that and to help them in that way. Then we get referred patients with truly complex valvular heart disease or other issues that just don't have another solution. And that may be patients here in the Northeast Ohio area, or within the state of Ohio, throughout the country, and throughout the world. So I do co-manage a lot of patients, and that's one of the benefits of being here. Now that we can do virtual visits, seems to be even more common that I'll be co-managing a patient in California, or even overseas sometimes. We have a robust virtual second opinion program, which is great for patients who are not yet even formal patients of the Cleveland Clinic. But it's a major part of my practice, and it's one of the most fun things that I do is serving that role as someone who maybe needs another opinion, already has a cardiologist, has a tough problem to treat, and through myself and my colleagues here, many of which are at the table, can come up with a solution that maybe they haven't been offered before.
Thank you, Dr. Reed. How about you, Dr. Tagan?
Yeah, I think getting a second opinion is important. A thing is available to us within medicine. I think that's always useful when you're not sure. I mean, honestly, we do this for our family members all the time here, right? It's part of what is great, is that someone will call and say, hey, my doctor said I have AFib, what do you think? Or they'll say I need a stent, and I'll go find Dr. Reed and ask him what he thinks about that. And so we're doing this with each other all the time, and I think that especially within EP, that makes sense, because it can feel a little esoteric. A lot of people have never heard of what an electrophysiologist is, and then suddenly someone needs an ablation, and that doesn't make sense, and it feels like it's science fiction almost. Probably a quarter of what I see are second opinions, and many of those patients end up having whatever they need done here, but a good number I will talk to and say, I think it's terrific, that they are on point and you should go with what they're doing. And I know providing that reassurance is very important to those patients, and I view it as part of the responsibility and honor of being at the Cleveland Clinic.
Dr. Suraju?
No, I absolutely agree, with everything that's been said. Medicine's not always black and white, right? A lot of the medicine is in the gray. One of my former chairs used to say, we make our money in the gray as cardiologists. We don't make it in the black and white situations. And so when things are gray, a second opinion helps. It helps at least provide reassurance, as Tyler said, that the decisions are being made are in line with what the patient thinks, and having a second person or a third person sign off on the plan of action can be very helpful, even if nothing changes at all.
Right.
And the model of us being a patient's second cardiologist or even third cardiologist is something that I think we're all very comfortable with, respecting the relationship that they have with their primary cardiologist and helping and supplementing where we can, is a model we're all very comfortable with. So I don't think there's much gatekeeping there in terms of having people come see us if they're concerned or if their physician is concerned.
Right. I agree. I echo and agree with all of your sentiments that typically most people are worried that their local cardiologist will be upset if they're coming in for a second opinion. And how I comfort these patients is saying, we'll all work together. I think you must keep your local cardiologist, absolutely. But for some things at a smaller hospital, the hospital just doesn't have the capability of all the innovation that we have here in Cleveland. But we see this all the time, that I'll have patients refer to me for a heart transplant evaluation or LVAD evaluation. And sometimes all they need is tweaking of their medications. They don't need to go down that pathway. But truly, if they are advanced heart failure, this is the place to be. All the innovations and really working with all of you to try and delay that, or to give them other therapies that may delay an LVAD, may delay a transplant. So it really is an honor, like all of you, to work with you and to really help our patients, especially with the Second Opinion program, as you mentioned, Dr. Reed. Before we go, I'd like to say thank you to our panelists today for your expertise and your participation. Cleveland Clinic is nationally ranked and globally recognized as a world leader in cardiovascular care. We provide heart care at many locations across Northeast Ohio and beyond. If you need us, we would be honored to see you. Before the end of the week, you will receive an email with heart health resources, details on how to make an appointment, and a link to a recording of this event so you can view it again. If you have more questions, feel free to call us at 1-800-659-7822. Thank you for watching.